Hi, good morning. This is Abdallah Sabah from Jack Interventions live at TCT 2022, and I have the distinct pleasure to be with Dr. Greg Stone here to discuss the findings of the FAVOR-3 China clinical trial that was presented as a late-breaking in the late-breaking science session and simultaneously published in Jack Interventions. Dr. Stone, welcome.
Thank you.
Pleasure to have
Thank
you. Dr. Stone, can you please, for us who were not at the session, can you please let us know about the trial, the design, what the trial was looking at, and some of the results that were presented?
Sure. Well, FAVOR-3 China was a very large study that enrolled 3,825 patients undergoing PCI in China that had at least one lesion between 50 and 90% stenosis severity. And the real question is that we know that in patients, particularly troponin-negative patients with, quote, stable coronary artery disease, we know that using fractional flow reserve or IFR, pressure wire-induced physiology, can be useful to select lesions. So there's a new technique which is called QFR, which is an angiography-derived fractional flow reserve correlate, which has been developed by a company. There's several companies that have actually developed this. And you can get that from the baseline angiogram. So you don't have to use a specialized pressure wire. You certainly don't need adenosine. It reduces costs, et cetera, and speeds the procedure. And you can get it based on angiography of every lesion in the entire coronary tree at baseline. So we ran a very large trial. The principal investigator was Zhu from Beijing. I was the co-principal investigator. And a very large trial, 3,825 patients, in which half the patients had routine angiography-guided PCI, and the other half had their PCI guided by this angiographic-based QFR, such that if the QFR was less than or equal to 0.8, you would choose that lesion and treat it, and if the QFR was greater than 0.8, you would defer it. And in a substantial proportion of lesions, about a quarter of the cases, the decisions were changed on the basis of QFR. And we had previously reported and published in the Lancet at 1 year that QFR led to a substantial reduction in MACE, approximately a third reduction in MACE at 1 year. And by preventing both myocardial infarctions, mostly late myocardial infarctions, as well as recurrent ischemia-driven revascularizations from restenosis. And we now have followed the patients out to 2 years, and the results have become even more dramatic. The curves have continued to spread. We saw the same 1/3 reduction from 1 year to 2 years. So we see it constantly from basically the time of the procedure out the way all to 2 years. And there's about an absolute 4.5% benefit favoring the QFR lesion selection strategy, both by prevention of myocardial infarction as well as repeat revascularization procedures.
No, fascinating. Now the toolbox of coronary physiology is expanding.
It is.
And how do you see that being integrated in the near future?
Right. Well, I think that, for many years now, the guidelines have recommended with class 1 level of evidence based on the early FAME trials that invasive pressure wire-based physiology assessment is useful for lesion selection. Subsequent studies have questioned some of those guidances, but principally in patients with acute coronary syndromes, troponin-positive acute coronary syndromes, where there may be other drivers to plaque instability. But I do believe firmly that to guide PCI in patients with stable coronary syndromes, mostly biomarker negative, whether unstable angina or even stable angina, that you can use physiology to very accurately select which lesions are causing symptoms. And it basically is looking for more severe obstructive disease, and we also know that those are also lesions that tend to go on and cause myocardial infarctions. So now we have a tool where you don't need pressure wire to be passed down a vessel. If you were an FFR proponent, you don't need adenosine and hyperemia, which causes complications in some patients and it's expensive. You've got a much simpler way. And you, again, with pressure wires, you have to select which vessel to use. With QFR, you do it just based on angiography, and you can look at all 3 vessels, and you can plan your procedure. So I expect that angiography-based assessment of physiology is going to become standard in many, many cath labs. And we've seen that while we haven't yet compared it to invasive pressure wire assessment, that's the next step. That'll be the next large randomized trial that's being done in Europe, FAVOR-3 Europe. that, at least based on what we've seen now, this is a substantial improvement in outcomes in the largest physiology study to date at 3,825 randomized patients. So I think this will become a new standard of care in many cath labs.
Fantastic. Thank you so much, Dr. Stone, for your time and the insight. And for all of you, please find the full text in the current edition of JACC Interventions, and thank you for your attention.